Yes, my name is Professor Ulrich Frey. I'm head of the Department of Anesthesia and Intensive Care of the Ruhr University of Bochum, Marien Hospital here. And I'm the director of the University Hospital here, and we care about more than 15,000 patients a year. My experience, I've about 20 years of experience doing anesthesia and critical care. And I also have a big experience in hemodynamics, using also echocardiography, pulmonary artery catheter. I've been working a long time in the cardiovascular surgery anesthesia department. So my background is very much the hemodynamic cardiovascular field in that way. What is intraoperative hypotension? Intraoperative hypotension is the drop of blood pressure below a predefined threshold, which is intra-individual different. So every patient has per se another threshold of hypotension. But when we look at retrospective studies, then we should know that there's one critical value for adults, which is like 65 millimeter of mercury. And most of the studies have shown that the blood pressure should not fall below this threshold. So there are newer studies coming out which have shown that even in healthy patients, a higher blood pressure should be a safe blood pressure. So the lowest value should be 65 millimeter of mercury. Well, there are certain ways. Normally you can measure it via oscillometry, like non-invasive, but the better way of measuring blood pressure is using an arterial line. And the problem using oscillometric measurements is that we have a gap of blood pressure monitoring. For instance, when we have a 2 or 3 minute delay for using the next measurement. So the best way of measuring blood pressure is using arterial line, that we have continuous blood pressure monitoring. And even so, there are also newer studies showing that measuring blood pressure, invasive blood pressure below induction of anesthesia is safer for the patients, because we are able to identify hypotension or potential hypotensions even in the induction period, and this is a very sensitive period. Well, the induction period is very critical for the patients, because the patient experience vasodilation because of the drugs we are giving to the patient. And the patient, because the patient's lost his consciousness, is losing his possibilities of just doing a vasoconstriction, and that is the reason why the patient has most of the time hypotension. And another point is we are using very often an epidural catheter. And the epidural catheter results when we give drugs via the epidural catheter. The patient, it results also in a sympathicolysis, and this also results in a vasodilation. And those things together, these two things, induction of anesthesia and epidural catheter, both are points that could result in a critical hypotension period during the induction of the anesthesia. So the definition of hypotension is not only the hypotension itself, but also the severity of hypotension. So how deep the blood pressure falls below the predefined threshold, which could be 65, and also the duration. And we all know from the literature that the more the hypotension occurs, the higher is the risk for adverse events. So it's not only the hypotension itself, but also the severity and the time span, the cumulative time span of the hypotension itself. And that is the best way to define the hypotension. Yes, the time weighted average is what I already explained. It is the sum of the hypotension periods and the severity of the hypotension. And this is combined together. And this is a value in millimeter mercury, which gives us a very good value to compare different patient cohorts in terms of severity and time of the hypotension. And that is, I think, the best way how to reliable see the cumulative time and severity of hypertension. Hypertension is very prevalent. Data from the literature shows that was published in 2020 in very sick patients that they investigated more than 20,000 patients, and they could show that hypertension occurs in more than 80% of patients in these operations. These are operations with a time span of over more than 120 minutes. So hypertension is very prevalent, and in this study, only hypotension after induction of anesthesia was investigated. So we know that 1/3 of hypotension episodes occur in the time of the induction of anesthesia. So we must admit that there are even more hypotensive periods during surgery, and therefore hypotension is very prevalent. Well, to treat hypotension, we could give fluid for hypovolemia, vasoconstrictors for vasodilation, or positive inotropic substances for diminished contractility. Concerning hypotension on the ICU, it's even more relevant that we identify the potential reasons, because patients could develop heart problems on the ICU, or they could bleed, or other things could happen, which then develop a little bit more slowly. But it is even more critical in that situation that we find the right treatment for that patient, and therefore hypotension on the ICU is a relevant concern, right? I think there's not a real difference, because hypotension is one symptom of hemodynamic instability. So hemodynamic instability could result in hypotension. Hemodynamic instability could also result in a maintained blood pressure. But when the patient develops hypotension, then we have for sure a hemodynamic instability. But it's not always the other way around. We sometimes have hemodynamic instability without sudden hypertension. For instance, when we have a patient in an accident with a polytraumatic injured patient, then this patient, when he's awake, is hemodynamic unstable, but has for a very long time maintained blood pressure until he develops shock symptoms. So hypotension is always a symptom of hemodynamic instability, but it's not always the other way around. The consequences are, there are a lot of consequences, and one of the consequences could be organ failure, for instance, acute kidney injury or heart injury. Finally, maybe potentially resulting in myocardial infarction, for instance. Another possible consequence could be postoperative cognitive deficit. This is a major issue right now, even in nowadays, where patients are older and older and get into surgery and into major surgery. That's a big issue. We should think about. These are two potential consequences, and also other organ failures. For instance, what is not so well investigated is what are the consequences of hypertension to the bowel and intestine. And we know we have a lot of surgery, intra-abdominal surgery, where we have some maybe potential problems with bowel movement afterwards and so on. And we know from experiments in animals where hypotension results in a delayed restorage of bowel movement. And that's also a concern for postoperative care, for instance, for the intensive care unit. The HPI is a number between 0 and 100, and the higher the number is, the higher is the probability of the patients to develop hypertension within the next couple of minutes. And when the HPI reaches the number of 85 and is higher than 85, the machine gives alarm, and then there's a very, very high risk of the development of hypertension in the next, for instance, 5 minutes. That is the HPI. The HPI has much more information compared to FlowTrack because the HPI also gives information about the contractility of their heart, which is displayed as a value. And there's also another information concerning the relationship between pulse pressure variation and stroke volume variation. And these are the more information the HPI gives us, because the HPI analyzes the pulse pressure curve exactly, and from all these information, the number of the HPI is calculated. Therefore, the HPI gives much more information, not only as a number, but also as more information concerning contractility and afterload. Yes, I think that's a very good and important question. We are all working in real-world conditions. So when we care for the patients in the operation theater, we care in like real conditions without so many people doing studies under controlled conditions. And therefore, I think a study like a pragmatic study doing just investigating how the situation is in real life gives the best information for the care for the patients. And I think that's sometimes a problem with prospective studies where we have a lot of investigators caring about one patient, which not mandatory reflects the real situation. And I think we might, I don't know, but from my perspective, we might get better information about how to care for the individual patients if we have situations where the doctor is not aware that he or she is part of this study, because in that situation, the doctor is caring the patient the way he or she always does. So we did a pragmatic study using 100 patients with major abdominal surgery, so high-risk patients with which were also very 608A3 classification, most of them, and 50 were on HPI and 50 were on FlowTrack. This was a retrospective analysis. And in this study, we could show that using the HPI, the risk of hypotension or the hypotension episodes were 5 times less in the HPI group compared to the FlowTrack group. And that was a very big difference. I actually work most of the time with the secondary screen, because the secondary screen gives me the best information of the potential reason for hemodynamic instability. And this is preload, contractility, and afterload. And also we have the best information about dynamic changes, because we can see in a small window the changes over time, over a certain time. And therefore I can see what happens to what system in the last 5, 10, or 15 minutes regarding preload, contractility, or afterload. Yes, first contact was that when I started here in my actual position, like 4 years ago, we were working with the FlowTrack or the ClearSight system. Then I contacted the Edwards people just to help me to make real good decisions working with that system. And in that situation, the Edwards people came up to me and said, okay, we have a new device, which is called HPI. Are you interested to test this out? And then I said, yeah, sure. I like to see what is happening then there. And then the connections to Edwards were better and better. And I went to workshops to see how the HPI worked. And then we were trying this device in our institution. And that was the reason maybe that we were the early adopters, we were actually the first hospital in Germany who were using these sensors outside of clinical studies, because we were convinced that this is a very helpful device for the best patient care. And another thing is that the connection and the discussion with all the people from Edwards helped us a lot for getting better and better, and to get into the positions where we are now, to have workshops on our own just to teach others which are on the first step of using the system, because it's not so long ago that we were in that position, and we see what the obstacles are when you just begin to use that system. What problems you might experience with the surgeon, with your administration, with the nurses, and so on and so on. And I think that is because we talk from our own experience. The obstacles are mainly logistics, that we need to have a system ready in the operation theater with all the cables, sensors, and so on and so on. And we need to have everybody involved, the nurses, the surgeons, and the anesthetists. And that is the team. And the system does not work without the surgeons. Why the surgeons? Because we need to convince them that we have a system which can really help the patient. And I would like to give you an example to make this clearer. We had patients which have a robotic surgery, and the patients was on the 30 degrees head down position on the table, and which could have some changes to volume and heart contractility and so on and so on. And we were also using the hemisphere monitor and this monitoring device. And at some point of the surgery, the blood pressure was stable, but the cardiac index and all the contractility value were falling down. And we talked to the surgeon that something happened, and then the surgeon was asking, how is the blood pressure? So, because this is the value he knows. And we say, the blood pressure is good, but the other hemodynamic values are very bad. And then, because the surgeon knew that we are using the hemodynamic monitoring, then the surgeon was aware that we are doing a good job using that system. And then we said we cannot go on with the surgery in that positions. We have to get the patient in normal position. And the surgeon says, okay, when you tell me that, we do this. But the surgeon will only follow you when you are a good partner, and then you have a good connectivity to that in that situation. And that is the reason why we need the surgeons as partners, because the surgeons must follow your advice in that situation when you need to change your therapy, which could also result in a change of surgical procedures. And the nurses are also very important, because I think we are a team, so we are team players, and the nurses need to interpret the values most of the time, not the full same way like we do, but we need to get the help from them, because they have to prepare the machine, the device, and all the equipment. And without them, it wouldn't be possible to have such a complex machinery going on. And these are the main obstacles at the beginning. And we are still working every day. We need to start over again and just to convince a lot of people. It's an ongoing process. This is a point which is very critical for teaching younger colleagues, because the system is very useful for for the whole hemodynamic experience in one patient, when I want to say like that, because we see preload contractility and afterload. We can calculate oxygen consumption and delivery, and all the values we learned when we were learning physiology. And the residents in our hospital, everybody wants to work with that system because it's a really good tool to I show on my slides physiology live, because we can see on the monitor what happens when we give fluids, when we give a vasoconstrictor or inotrope. We can all see the values, and this is a point where all the colleagues which trust the system or which are open-minded want to work with. That's a good thing. Well, my philosophy or my mission here in my department is that also the nurses and doctors are belonging to one team. We have a lot of team events. We are going sailing together and so on. So we are training critical situations together, and that is my vision, that we have to work very closely as a team, and that's the same using new technology. So I always ask the nurses at the first site to say, okay, we need you. You have to help us with the things we are doing, implementation, everything like that. We need 1 or 2 people from your team who are responsible for the monitor, for the setup, for the logistic, for the patients, they take care of the patients before we start. And also when we do our workshops, we have 2 fantastic nurses who make talks, who make teaching, and so on and so on. And that is also a big point, which is always discussed in like everywhere we go, that the nurses are so important to make this thing successful. The first step is that we go to the literature and we just look what protocols others are using. And then we look whether there's certain protocol which fits best to our needs, because in our clinic we have the enhanced recovery after surgery protocol, and we use goal-directed therapy protocol which fits best in this ERAS protocol. And we have a full picture right now. We have an ERAS protocol and a goal-directed therapy protocol which is modified to our needs. And this was also like an evolution of the protocols, because we are not using the protocol anymore which we are used at the first time. So we've done many more steps until where we are right now. I think it's always good to use a protocol, because you always get an advice of what could be the reason for hemodynamic instability. I think an experienced anesthetist is also looking at the protocol to see whether it is right, what his or her first thoughts were. And in most of the cases, when you are an experienced HPI user, you don't need to look at the protocol, because what you're thinking is also the same what is in the protocol. Because there are some slight modifications, like, when we look at DBTT, like whether it's 400 or 300 or 500. So it depends on what you are thinking or what was the patient's baseline values. But in principle, even the experienced user also look at the protocol to get an advice. So the feedback is almost positive. Most of them are positive, because the surgeons think that there's another machine or device which helps us to get a better patient care, and the surgeons are also interested to get the best care for the patient. That is the feedback from the surgeons. That is a very good feedback, and also from our colleagues from other clinics. We also get very good feedbacks. What we see when we do our workshops from other clinics and hospitals, they ask us how we do this and that, and so the feedback is very good. So we are very happy with that. Concerning outcomes, that is what we are looking for right now. We have a registry study going on in our clinic, just investigating whether their reduced ICU stay or reduced acute kidney injuries. That what we are investigating now, and we want to just compare different time periods, like in the time period we were using HPI, which is right now, and that comparing to the time period before implementing HPI. But we have to, there's some bias when we look at different time periods, because surgeons, maybe their surgery is getting better and better over time, so we have to keep that in mind. That is, that there's a bias, but that's what we are investigating right now. Yeah, that is a very interesting study. We were planning, and we are starting right now in the next couple of weeks in pregnant women undergoing cesarean section, where we want to use the Acumen IQ cuff, which was just approved a couple of months ago in Germany. And we had to wait until the cuff is approved, because it had to go to the ethical approval, which is finished right now. And we want to compare like normal non-invasive blood pressure measurement compared to Acumen IQ cuff blood pressure management in terms of hypotension episodes in women with spinal anesthesia in C-section. And this is very interesting, because we normally do not use an arterial line in these patients, but we want to have continuous blood pressure monitoring in these women, because it's not only important for the woman, for the pregnant woman, but also for the unborn kid. And we know from the literature that hypotension episodes could have a bad outcome for the baby. And that is what we also want to investigate. And this could be a very good endpoint, and not besides from hypotension episodes, which comes along with nausea and vomiting. And this is what we also want to investigate. And we are pretty happy that we can perform this study, and we are looking forward to seeing the first results. Yeah, it's the usage here. One is what I already said, being like for C-section patients, or for like obese patients where a normal non-invasive blood pressure monitoring might not be possible, or in situations where we normally start with non-invasive blood pressure monitoring, like robotic surgery, where the patient is 30 degrees head down and something happens, we do not know what, blood pressure falls, and we do not know whether this is a problem in contractility, preload or afterload. And then there's a possibility to use the Acumen cuff, because it's not very easy to insert an arterial line in the patient where the patient is still down, and so on and so on. These are the indications here. So it's not in Europe, especially in Germany, it's not that we say, okay, we do not use an arterial line anymore, we do see a Acumen IQ cuff. I think that Germany, we use invasive blood pressure monitoring quite often. I think more often than in the USA. But there are really certain indications where, which I already said, which might be beneficial for the patients to use the system. When it might be improvement, because when patients get older and sicker, this is really an improvement, because comorbidities are higher, like the risk for AKI is higher, risk of myocardial infarctions are higher, and the surgeons want to do the surgery even in more sicker patients, and that is the patient group which might have the best beneficial effects of the system. We are not talking about like the 20-year-old healthy patients which might have a major surgery. We want to talk about older patients, the sicker patients, and that might be a good improvement of the healthcare system for the next years, because patients are getting older and older, and we have to face that, and getting more individualized care, not only like making the same treatment for every patient, but blood pressure is only one component, and we need to look at different components like contractility, preload, afterload, and so on, and also to find what is now the reason for the hemodynamic instability, to give an individualized treatment for the patient, not the same treatment for everybody.